Hello, everyone. Thank you for joining us today. Hello, everyone, and welcome to the first Open Academy Masterclass. My name is Marta Campabadal, and I'm the Open Academy e-learning and outreach coordinator, and I'll be today's host. We'll start in a minute. We're just letting all the people into the room and giving them a few moments to get settled in. Perfect. So if you've already been in one of our meetups, you know the drill, but we have lots of new people today. So let's quickly go through some housekeeping. This is going to be a long session. It's 2.5 hours. It's going to be recorded and later added to the alumni private page in a couple of days. Use the chat to introduce yourself and ask questions to the panelists. During the time for question and answers, you can speak and share your experience with the group. You just need to click on the raise hand feature and I'll give you the floor. And finally, we've created a short survey to assess your satisfaction and see how we can improve our future trainings. At the end of the session, once the Zoom will close, a survey will automatically open in a new browser tab. But if you cannot stay until the end, we'll put a survey link in the chat in a few minutes. So let's get started. First of all, let me tell you that this topic has been the most requested topic since we started doing the alumni meetups in September 2022. I think we all know and we all can agree that patient input throughout the development of prompts is essential to ensure that outcomes that matter to people living with rare diseases are appropriately captured. But sometimes it's also difficult to learn more about this topic as a patient advocate. Sometimes there are not enough opportunities. So that's why we've put together this masterclass, so you can have a better overview of the basics, the role of patient organizations in development of patient-reported outcomes, and also to show you what resources already exist. We hope that this will be a great introduction to a complex subject and that you leave today feeling motivated to find out more. So we've put together a beautiful panel of speakers today. We have with us Dagmara Kulis, linguist specialist specializing in patient-reported outcomes at the European Organization for Research and Treatment of Cancer. We also have with us Elizabeth Broom, founder and president of the Duchenne Parent Project in the Netherlands. Also Mariangela Pellegrini, educational and patients program manager for the ERM EuroBloodNet. Gavin McDonough, project manager at Orphanet, and Celine Desvigne-Glezes, outcomes researcher at Mapi Research Trust. So today's agenda consists of 20-minute presentation followed by 10 minutes of questions and answers after each presentation. And in the middle, we'll do a quick 10 to 15 break. And after the last presentation, we'll do a final Q&A and the group discussion. As I mentioned earlier, this session is being recorded, and also the recording plus the slides will be added to the alumni private page in a couple of days. And in that page, you will also see references to the next Open Academy meetups. The first one is going to be the 22nd of September, and it's going to be an introduction to N-of-1 trials with Annemieke Arsmars-Roos. And the 19th of October, we'll do a session with Michela Onali on how to get started in research. So I'll stop sharing now, and I'll hand it over to Dagmara, who is going to do the first presentation.
Sure. So I will share my screen. And can you let me know if the slides are visible?
Not yet.
Not yet. That's weird because it worked.
Yeah, it just worked a few minutes ago. Yeah,
Yes,
it's loading.
yeah. Okay, yes. Now?
Perfect. Yeah, perfect.
Yes, perfect. Oh, oof, that's good. Okay, so thank you very much for the invitation. I'm always happy to share our experiences and yeah, help spread the word about PROs. So my name is Dagmara Kulic. I'm the associate head of the Quality of Life department at the EURORDIS. And yeah, as Marta said, that's a European Organization for Research and Treatment of Cancer. So everything that I'll be talking about is from the oncology field, but it is very transferable to any other disease in the PRO world. So I was asked by the other panelists to set the scene with some terms so that we have clarity on what is what. So the patient-reported outcome, PRO, one of the most used words in my world, we can define it as an outcome, so something we can measure that is reported directly by patients themselves and it's not interpreted by an observer. So we have some outcomes that are interpreted by an observer, for example, the 6-minute test, or when we ask proxies to report on the patient's experience. Here we are talking about the patients themselves. And then we have the PROM, which is the patient-reported outcome measure. So this is basically the tool that we use to assess a PRO. So it can be a questionnaire most of the time. That's what I work in. In real life, those two words are used very interchangeably. A lot of the time, sort of not correctly, but yeah, we have to just keep in mind that yeah, it can be PRO can also be meant as a measure. But those are two terms. So let's start with the need to assess quality of life, which is one of the PROs. So according to the World Health Organization, there are 3 main goals for cancer diagnosis and treatment programs. So we can measure the progression-free survival, which indicates the curative intent of the treatment. We can think about considerably prolonging the life, which then leads us to focusing on overall survival. And then we have the goal of ensuring the best possible quality of life. And that means measuring the health-related quality of life, so the HRQOL in patients. That led to the creation of a quality of life group at the EURORDIS network that put it as a goal to make it possible to measure health-related quality of life in cancer. And they published a strategy on how to assess quality of life and then guidelines on how to develop good quality of life questionnaires. When we talk about quality of life, we have to think about the fact that it has 3 main characteristics. First, it's subjective, so it is patient-reported, it's a PRO. Then it is multidimensional, it covers different aspects, and then it's dynamic, so it changes over time. And then it is a very valid question to ask, how do we measure such a concept that is subjective, multidimensional, and dynamic? So that's where we get to questionnaires or prompts. Here is an example from the EURORDIS QOQ-C30, and we can imagine that we have a patient who has to report their physical functioning, and they answer like this. So they have just a little bit of trouble doing strenuous activities. They have no trouble walking. They have no need to stay in a chair during the day. They have no need to help them with activities of daily living. We can sort of say that's a relatively healthy, active person with a high physical functioning. And then we have the same questions with another set of answers. So here we have somebody who has a lot of trouble doing strenuous activities. They have quite a bit of trouble taking a walk. And so we can say that this person has a lower physical functioning. So this way, through the questionnaire, we can differentiate between 2 groups of people who have different level of physical functioning. The same questionnaire can also show us the change in one person over time. So we can imagine that at the point of cancer diagnosis, the person is feeling relatively okay when it comes to their physical functioning. But then at month 3 of treatment, if there are lots of side effects and adverse events, then they might feel much worse. And then when the treatment is finished, they will go back to baseline. So that shows us their physical functioning across time. The question is, there are lots of questionnaires out there. So how do we get a good PROM that measures what it's actually supposed to measure? And that's not as simple as just, writing down some questions and giving them to patients. So as I said, the EURORDIS Quality of Life group came up with an assessment strategy, which is based on having the QLQC30, which is a generic core questionnaire for all cancer patients, and then having modules that are either disease specific, so can be directed at breast, lung, head and neck cancer patients. They can be symptom specific, like patients who suffer from fatigue or from neuropathy or cachexia. They can also be population specific, so like a special questionnaire for the elderly or for adolescents and young adults. And then we have some other questionnaires that focus on different aspects of care. This way we can get a really holistic view of the patient's state and their and how they go through their disease and treatment. All those questionnaires as questions are available in our item library, which is a database of all the questions that have ever been developed by the EURORDIS Quality of Life group, which is a very good resource for basically anybody who is interested in PROs. It is just an online database that has all the questionnaires, questions, translations, and also allows people to make their sort of custom-made item lists that they can use in their own research. So this item library is the current version, but it started already in the 1990s as this very retro-looking website that served basically just the purpose of being able to consult what sort of questions are there already. But how do we develop a questionnaire that can be considered a good PROM? So the EURORDIS approach is very standardized, and it consists of 4 phases, and I will quickly go through all those. And every single questionnaire that we have in our portfolio had to go through all those phases. That's absolutely necessary. So one of the main sort of building blocks of the quality of life strategy that we have is that it's very patient-centered, and that patients are at the center of every phase of the development, and they are consulted and they are interviewed, and they can share their experience about the questionnaire that is being developed. So that's very important for us. So in phase 1, we collect issues. So that's done by literature review. So the developers, the researchers check what is already out there, what sort of questionnaires already exist in the topic that they want to have a questionnaire in. They check papers, and this way they collect any issues that the patients might be struggling with and that might be important to the patients. And then we also do focus groups where patients and healthcare providers who work with those patients are interviewed. This way we can collect issues which are something like here, keywords of things, problems, important questions for patients. This way we can create a really exhaustive list of all those issues. Then they are rated by both patients and healthcare providers to come up with like the most important 50 or 60, because normally if you collect all the possible issues, we end up with like a list of 150 to 100 issues. And of course, it would be a bit excessive to have a questionnaire with so many questions. So we have to choose the most pertinent ones, and that's done by ratings. Then from those quite ugly keywords, we have to turn them into beautiful questions to have a proper questionnaire. And that's done in phase 2 when we turn issues into questions. And that's a very important sort of exercise, because for each issue you can come up with a whole lot of different questions. So if you have, like here, being judged, you can ask if the patient felt like they were being judged, or if they were afraid of being judged, or they, there are lots of different versions of that question for one issue. And so here, for example, we can, for a symptom, we can ask about the presence of a symptom, about severity, about burden that it constitutes to the patient. So that's very important to decide what the question has to actually measure. And this way, we can also use the item library to see what questions we already have from other questionnaires. So that's a very simple thing. The issue can be input in the search box, and then we see all the questions that correspond to that issue, and we don't have to reinvent the wheel each time there is a need for a new question. Once we have a preliminary questionnaire, we do what we call the translatability assessment. We analyze the questions to make sure that they will work. We know about some issues that will, just create problems when we have to give the questions to patients and when we have to translate the questions. So this is a totally fake example that I made up, because I hope there is not a question out there that is that bad. It just shows a few issues that might be a problem. So we check if the question is not too long and not too complex, because we don't want to have really long questions that are difficult to understand. We also know that when we translate them into other languages, they might become even longer. So that's really not a good thing. We don't want questions that are double-barreled. That means that they ask about two different things, and that might be very confusing to patients who they might have problem only with one of those two things. So they might have a problem with which answer to choose, because they will be confused. We don't want questions that use a negative, because that might become a double negative in some translations, and it might not fit the response scale. Then we don't want any idioms, because they are difficult to translate and to really show all the cues that the meaning is in English. There are some words that we try to avoid, like troubled is quite difficult to translate. Bother, that sort of words that we already know from experience will cause problems. And then we check if the response scale that we have in the questionnaire actually fits the question. So if it's possible to answer that question with the given response options. So when we have fixed our possible problems, we can start with the translation of the questionnaire, because we always do the development of our questionnaires in different countries, so we need different translations, and it is a very important process, and it follows quite a standard procedure. So first, it is translated from English into the target language by two people. Then there is the reconciliation process, where the two translations are combined, or one of them is chosen to come up with one optimal version. Then this version is back translated into English and reviewed by our translation unit in the Quality of Life department. We have a discussion with the translators to make sure that the meaning is right, and all the issues that we identified in phase one are properly reflected in the translation. Then we do a review by the collaborators in each country to make sure that they agree with the translation, and then we do final proofreading. And this way we have a translation that is ready for testing on patients. And then we go into the phase 3A, which is a small pilot testing, or like cognitive debriefing, where a small group of patients, so by small I mean around 15 people per language, per type of patients, because that also depends on the disease. They receive the questionnaire, they fill it in, and then they are interviewed about their experience. So they can yeah, they can comment about any difficult words, about any problems that they experienced when they were filling in the questionnaire, about any upsetting items. So yeah, they can just comment about anything that is related to the meaning and the wording of the questionnaire. And all their comments are then analyzed to adapt the questionnaire to make it better. So, for example, we can reword a question if it's not understood, or we can add examples if people had problems with understanding, or we can delete questions if they did not really work. So this was phase 3A. After all those changes, we have the next version of the questionnaire, which we can then go further with to the initial psychometric testing. So this is done on a bigger group of patients who fill in the questionnaire, and then the psychometric properties of the questionnaire are analyzed, the scale structure and the psychometric characteristics. After those that part of the process, we still expect some changes, especially deleting questions that don't perform really well, and that this way we can come up with a questionnaire that is shorter. So that's always also desirable. And then the last phase is the big field testing, which is done in a relatively global way, like with a lot of countries, not only Europe, with hundreds of patients, to really establish the characteristics, the psychometric characteristics of the questionnaire, and to make sure that it works the way it should. So the question we get a lot is also from people who work outside of cancer, and it is to ask if they can use the item library to develop a PROM in an easier or a faster way, because the way we do it, yeah, it takes time. I think the fastest that we ever had a questionnaire developed was something like 6 years, and it requires quite a lot of money and effort and hundreds of patients. And so we do definitely allow that, and we say, yes, it is possible. And so it even is possible following our way of developing questionnaires, because yeah, you can do phase. Why is it not working? Yes, you can do phase 1 with a relatively small number of patients, just to get the issues that are important, that have to be covered by the questionnaire. And then you can use the item library to come up with the preliminary items that we already have. And then the cognitive debriefing can be done, or if the questions come only from the item library, it can even be skipped, because those questions have been tested on patients and we know that they work, and they are also available in quite a few languages. And then the preliminary testing can be done on a yeah, not such a big population of patients, skipping the big field testing, which is the most sort of time consuming and cost part with high costs and difficult to organize. So it's definitely possible to create a PROM with what we have, also for other diseases. And we already had quite a few examples of that. So once again, this is the item library, and it is quite easy to search. We also have different ways to classify items that makes it easier to choose the right ones. So for example, we have the CTCAE classification that allows you to look for, according to the adverse event classification, and the items we have are mapped to the keywords used there. And this way you can just select the items from different questionnaires and put them together into one questionnaire that is ready for use. We have had recently a paper that is actually, yeah, it's instrument agnostic. So it's about any item library, because there are more than just the EURORDIS one, on recommendations on how to use them for PROMs in oncology trials. But this is actually quite a yeah, good paper on general use of item libraries for creating questionnaires for any disease, and it explains how to check the validity, how to make sure that they work and that they are made in the proper way. I think it's still available in open access, and if not, I can surely share a copy if somebody wants it. So yeah, thank you very much. I'm happy to take any questions.
Great. We have quite a few questions. I think the library sparked a lot of interest. Let me start by Sheila's question about the library. Would the library be available also to independent patient advocates or just patient groups?
No, it's available to anybody. You just have to go to the main page and fill in the access request form, and then a colleague of mine will get back with a very basic access agreement that has to be signed via DocuSign. So it's a quick process, and then you have access. So it's available to anybody.
Perfect. Yeah, you already answered. Okay, you already answered the next question, which was about how to access the library. There's like a request access button, and you just need to fill out the details.
Yeah, exactly.
Perfect.
So I will put the link again in the chat if anybody wants to have a look. And there is a button called request access.
Yeah. Perfect. Werner has a question. How many hours of work before field testing do you need?
Yeah, a lot. As I said, it takes a few years basically by the time all those phases are done. So this is a very time-consuming process. But yeah, that's what it is in this case.
Next question is from Gina. The translated version of a survey will also need a test in order to make sure that the content is clear enough for the group we are addressing to, or with the test run by the original language is enough? So
that sort of depends a bit on the questionnaire and how it is developed. We always develop questionnaires in a multi-language, multi-country setting. So we do that testing, the pilot testing or the cognitive debriefing already in a number of languages, and those translations are then compared between the languages to make sure that the testing is done in a multicultural setting. If we then develop a new translation once the questionnaire has been validated, we also test it in that language on patients for understandability. But for the psychometrics as such, it should be transferable from a well-validated, well-designed questionnaire onto its translations. But it's still very important to follow the good translation procedure of not just giving it to one person who translates it and that's it. So yeah, it has to be done the proper way.
Yeah. Next question is from Charlene. On the homepage of the EURDC Quality of Life Group item library, we see the item library is a database of items used in fully and partially validated EURDC Quality of Life questionnaires. What do you mean by partially?
So we have those 4 phases, and once the questionnaire completes phase 3B, we consider it partially validated but ready for use. We presume that it will not change in a major way, and that its basic characteristics in the psychometrics have been tested. So it's a way to allow people to use questionnaires a bit sooner and to not make them wait for 2, 3, 4 more years before the field testing is finished. So by fully validated, we mean those that finished phase 4, and by partially validated, we mean those that finished phase 3, at least. Yeah. They might be currently in phase 4, for example.
Very clear. And last question from Michael. Do you have any advice on created patient-reported outcomes which are accessible for people with limited health literacy?
Yeah. That's a very big topic. And yeah, I think, testing, I guess testing on the right population is the answer here. We try, when we develop questionnaires, to have a varied population with different levels of education and background and so on. But of course, since we work through our network that are hospitals and people who are mainly involved in trials, this creates a bit of a bias. So yeah, I would say, yeah, testing and being aware of those problems. And we get a lot of comments in phase 3A of, yeah, words being difficult and things that have to be adapted. So of course we try to do that. But yeah, there is no simple answer, I would say, to that.
Yeah, got it. So there are no additional questions for now. So yeah, I'll invite Elizabeth to the spotlight. And yeah, whenever you're ready.
Yes, I'll share my screen.
Yep.
So first of all, thank you for inviting me for this masterclass. I think I'm not an expert or working in the PROM, but I'm definitely an advocate of the development of PROMs, and we took the initiative here as patient organization, as patients, to do this. So there was a question, I think, how to involve patients in the development of PROMs, and I think this is an example where we really started from the patients. So I will go through it, what we did. In fact, it is about the role of patient organizations in PROM development, because I think patient organizations can take initiatives and also do a lot themselves. They don't have to wait till academics get started or are interested. And I think most of you might know what's Duchenne muscular dystrophy. It's mainly boys. It starts at a young age. It is progressive muscle breakdown, but also there's also mental involvement, not with all of them, but behavior and learning difficulties exist, and ultimately it's fatal. In the past, before they were 20, now there are more and more men living into their 30s and up to their 40s. So, but then, knowing in clinical trials, we saw that FDA, EMA agreed with companies in the past that the 6-minute walk test was the outcome measure for improvement. However, just to realize that only 10 till the age of 10, let's say 12, boys are walking. So the vast majority of Duchenne patient is non-ambulant. So drugs were not developed for this age group. And then when we asked regulators, companies, especially also companies, why are you not including non-ambulant patients in your trials? They said, well, we don't have an outcome measure for non-ambulant patients. And you can imagine, as patient organization, that is not an answer you can get, you know. So we thought, like, whoa, what's happening? And we found out a lot of people thought, like in companies, but also regulators, that if you can't walk, you know, that life is almost gone. So then the boys themselves said, well, walking is highly overrated. So we said we need outcome measures that can be used for non-ambulant patients. And I will show you some interviews later. But the interesting thing is, when we interviewed the patient, the non-ambulant patient, and they came from Italy, France, Netherlands, Germany, and they all said more or less the same. And that is, if I could put my hands on the table, so if I drive with my wheelchair to a table, put my hands on the table, then I can still use my computer. I can eat, even if it's with my head close to my plate. I can do something. I can brush my teeth. And so then we thought that should become an outcome measure. So first we started with a physical outcome measure. And then when we did that, we thought, like, okay, but starting from the patient, we at the end also need an outcome measure which is really filled out by the patient without interference of clinicians, whoever. And we developed the PROM as well. So it went hand in hand. So this is Justus, and I'll show, and it's not only Justus, there's also, okay, go, sorry.
Hi, I'm Justus, I'm 18 years old, and I live in Amsterdam. And today I'm going to tell you about what's important for me. For me, most important is that my heart and lungs keep working the way they do. And so without the ventilator, it would be great. I mean, just to be able to do things as normal as possible with as less equipment as possible. And then second of all, my arms are very important for me. I mean, yeah, without them, you can't really do a lot. And then my hands are most important to use them with typing, or for example, with the remote control of this wheelchair, because for me, it's also, I like it a lot, this wheelchair. I would like to be able to drive in it as long as possible. And then second of all, my lower arms and upper arms are also quite important, because now, for example, when I have to put my arm on the table, I have to do it like this, which hurts at your fingertips a bit. So it would be easier if you could just, lift your upper arm yourself. So that's something that I would like to improve a bit. And then for using the computer, it's also very important that your hands keep working the way they do. That's about it.
Okay, so this was Justus, but that's also Peter. I thought he was included as well. No problem. But it is all about the same, being able to put your hands on the table, what you can do with your arm. It's not about going back to walking. No one said, if I could walk again, that would be fantastic. It's all about arm function. And so then we formed we funded it as a patient organization. Of course, we did not develop this ourselves. We were part of a team, a working group with clinicians, physios, people who were capable of doing a rash analysis, who knew how to set up outcome measures. And also the companies were there as well to see if we were developing something which could be used in clinical trials for them. And so we did this functional outcome measure. We published it. I will show. Then we did the PROM, we validated. And now I can't see my last line, but you see it. It's owned by the patient organization, which is maybe not super usual, but for us, it's nice that we can, by making this available for clinical trials. And if it's a company, we license it. So we get some return of our investment because we paid all. And with that return on investment, we can again develop new outcome measures. So that's a nice way of doing. Of course, academics, clinics, clinicians, etc., they can all use it for free. So, and then co-creation is really a key word when you speak about patient-reported outcome, because without them, you can't do anything. And this is the same Justus, meanwhile, several years older, and an engineering industrial designer specific in this area. And so it's not only him, there are more people. It is important to go all the way, always back to the patient. Is this really what is important to you? So the aim of this project we did was to develop a patient-reported outcome measure which could assess the upper limb function. But again, starting from the wishings of the patients to activities of daily living that cannot be observed in a clinical setting. Specific for patients with Duchenne muscular dystrophy across a wide age range applicable in different stages of the disease. And then, why is it not going to... Okay, and the method we used was based on the US Food and Drug Administration guidelines. They have, so if you want to start, there are guidelines. They might be different now from when we started, but they are still there. And this includes item generation from a systematic review of existing tools and expert opinion to task difficulty and relevance involving individuals with Duchenne. And then the cultural aspects affecting activity of daily life were also taken into consideration, because if you want to use this at a global level, you need really to make sure that you don't ignore the cultural differences. You see my screen still, by the way?
Yes.
Okay, so at the end, the DMD specific upper limb PROM was developed on the basis of clinical relevance, psychometric robustness. Main purpose is to document the patient's self-reported natural history of DMD and assess the efficacy of intervention. And of course, a lot of these questions, it this prom started with the drug development questions, why not drugs were developed for older patients. But we see now more and more it's also used just in normal natural history, but also in patient daily care to see how their arm function is improving or declining. Most of the time, unfortunately, it's declining. So we published this. This is about the functional upper limb module for Duchenne. And you see that's 10 years ago. So then I think when you look at the publication on the development of the PROM, that is then 7 years ago. And I fully agree with what Dagmar said. It takes a lot of time to develop a PROM. So in that sense, I think the libraries who are existing are of ultimate value. And really, if you really can't find a PROM which fits your purpose, that is the moment to develop one yourself. Because just to have an idea, I won't read them all for you because this will be made available, but these are all the steps we had to take to develop this outcome measure. And often you really want to use them tomorrow, right? That is what you want. You need it and you want to have them. And that is not the case with a PROM. I don't say you shouldn't do it. I don't want to discourage you, but I think if you can find something which is already there and you can use, it saves you a lot of time, a lot of work. And in our case, in general, you could also say a lot of money, but we were really supported. All the scientists worked for free for us. Everybody was just doing their work in kind. So that was really nice. We only had to organize the meetings and so on. So involvement of different stakeholders guarantee the clinical relevance of the tools.
So hi everyone. So here today I'm not on my own. I'm with my amazing coworker Marie-Angela and Gavin. So we are both part of the EUREKA project. We are going to talk about this, but later on. I'm part of a nonprofit organization, MAPI Research Trust, who has developed a very important set of databases on patient-centered outcome. We'll talk about it later, but here I'm coming like as a patient-centered outcome specialist, and Marie-Angela and Gavin are more centered on the rare disease part and patient advocacy and disability management for Gavin. They will present themselves afterwards. But here is just to give you a sense of what are we talking about today? I mean, the three of us. The first question we would like to address is following the Mara presentation on how to develop a questionnaire following the appropriate requirements. Here we are going to talk about the consideration before even using one PROs. Then we'll have a presentation on how PRO could be useful for patient advocacy with a case study presentation by Marie-Angela. And then we're going to talk about the EUREKA project to see how the EUREKA project support all the initiative around rare disease and patient centricity, and especially on presenting few tools to help you to select the adequate prompts to use. And then it's also how patient advocate can contribute to this project. So let's start with this first chapter on what to consider before using a prompts, because using a prompts is first a very amazing step to try to capture patient voice and to provide insight on it. But there are a few considerations to consider before even using them, because you know that one size doesn't fit all, and it's important to know that one questionnaire can't fit everything. And the very first important step is to know what you want to measure. So the first thing is really to clarify the objective of the use of your questionnaire. And here are listed few, let's say, major objectives, but obviously you will have your own. But measuring what and what you need to hear from patient is crucial. So it could be, for example, describing the disease burden on patient's quality of life. It could be assessed quality of care, communication with a care professional or the support staff decision making. And it could be also to evaluate treatment or, let's say, any kind of intervention impact. So as soon as you have your objective clear, The context of use of the questionnaire is also important and will help you to select the appropriate prompts. So here is just an example, a concrete example on when I'm measuring depression, given a specific context of use, which questionnaire is I'm more inclined or it's better to use. So here, if you're more in the step of screening depression among a set of patients, then maybe what we call the HADS, Hospital Anxiety Depression Scale. It's 14 items, it's very quick to complete, and you get an immediate score that you can leverage, and you can automatically assess the level of depression of the patient in front of you. Then if you're more like you want to assess a program and to measure the depression impact on quality of life, here you have listed different type of questionnaires. You can see here the quality of life in depression scale, the DSS-36, and also the double PAA questionnaire with the module on depression. Here you can see you have a wide range of number of items. It starts from 6 to 34. You can easily see that 34 items, it's quite a lot. So here it's more appropriate for a single measurement, like here an assessment program. If you want to assess the midterm outcome of care on patients from a whole hospital, then this questionnaire, motivation and energy inventory, which is a bit broader than depression, could be a good choice to pick up. And if you want to assess the impact of an intervention, treatment, surgery on a patient and their level of depression, you can use the Montgomery-Åsberg depression rating scale. And as you can see, 10 items, very short. So it could be measured at different time points. So in a nutshell, the first thing to define is your objective, what you want to measure with the prompts. And then you can look for prompts, and according to the context of use, then you can refine this initial search by selecting the prompts that is actually measuring what you want to measure, fitting your objective and your context of use. And based on information shared by Dagmara to identify further validation steps that should be completed by using this previously developed questionnaire. But beyond validity of the questionnaire, acceptance by both the patient and the clinician is also critical. It's not something new, but it's something to take into consideration. And here are some criteria that could favor the acceptance by both the clinician and the patient. The first one is to be feasible, meaning that the questionnaire should be easy to use. Here it's a comparison between what is a numerical rating scale and a visual analog scale, with our two different type of scales measuring the same thing, but it's way easier to score with an NRS compared to a visual scale where you have to tick on the scale, just on the scale, and it's kind of difficult to get the precise score of the patient. The questionnaire should be also actionable, meaning that the score should lead to an easy decision here and a diagnosis. Here we have given the example of the PHQ-9, which the score allows to have different thresholds where you can have a better understanding if it's below 5 or between 5 and 10 or above 20, then you have a better understanding of the severity of the depression. Then also you should consider the context. As we have mentioned before, the prompts should be incorporated into the provider routine of care. That's why the DSS-36 with 36 items with it's long and it's a complex scoring. So maybe it's not the best appropriate tool to implement into routine. And last but not least, the questionnaire should be useful, meaning that it should contribute to better healthcare. And so that's why the objective of, to clarify the objective of why you're using prompts is very critical in terms of acceptance of the questionnaire itself. So here it was a very short introduction on what to consider before using them. And I will let Mariangela to introduce herself and to carry on how prompts could be very useful for patient advocacy.
Thank you very much, Celine, and also thank you to the audience for being here and to EURORDIS for this invitation, much appreciated. Indeed, so I think we have so already with the previous presentation why PROs and PROMs are important for improving patient quality of life. Then we saw how they are an important tool for improving not only patient-centric research, but also research. And now we are going to see how prompts are crucial also for advocacy itself. And we are going to show an example, a case study. Before, I will provide you already the answer, and then we are going through the example. So of course, prompts are tools that provide data and evidence on a content that is indeed individual and subjective. So this is a way for structure them in an objective way and to provide to the community at large, policymaker and scientific community, the result of everyone personal, individual, subjective way. Next slide, please. So with this example, I would like to show you what I've just declared. So how to structure from a subjective point of view on a treatment, on a disease, on personal quality of life to evidence. The example came from this questionnaire that was shared some years ago within the project ENERCA, that was the pilot of the ERN Euroblonet, Sombre rheumatological disease, the ERN I belong to. And it was to assess the patient's need and expectation on expert healthcare providers, so centers for hemoglobin disorders. Next slide, please. So as said, let's take this as example. So I'm a patient, I have some need, I want to express the need. I see that around me, all the patient community is expressing more or less the same need. So we have the patient community expressing needs, burdens, experiences orally in a not structured way. So we just kept it in a really orally structuration of need. Then we have the prompts, so the questionnaires and the results and the analysis of results that allow us to structure all those needs or those feedbacks and comments. Let's see how. Next slide, please. So taking the example from this questionnaire, it was assessed the transfusion, how patients perceive the quality of life and their time according to the time they spend in the hospital or centers for receiving transfusion. So as you can see, we start from a personal feedback. I spend a lot of time in the unit for receiving transfusion. I lose time for school or work. So we can identify from the personal feedback a need. So the provision of transfusion in a timely manner that is convenient for the patient's life. So he or she cannot avoid losing time for school and work. So we have the questionnaires. Patients community answered the questionnaire, and then we can claim that the majority of responders, so the 63, almost the 64% of people are transfused in the morning. And this is a data that could be claimed by the patient advocate for raising a need. Next slide, please. On the same questionnaire, the ENERCA one I've shown you, it was also asked about the adherence to the treatment of the center that was performing transfusion. What we saw that some patients were not transfused in expert center. So we saw that the 27, almost 28% of respondents are not treated in expert centers. So that means that they have no adherence to lifelong treatments. So as said before, we have a feedback. So I'm not transfused in an expert center, so I do not receive proper care or cure. Then we have the need, adherence to these to this support, and then we have the data. So we can claim that more than half do not adhere to treatment, so they can feel a lot of pain because it's one of the effects of lymphotransfusion specifically. Next slide, please. So we have these two data. How can we use them for advocacy? We can show that we have a quantitative evidence. So we pass from the qualitative perception of the experience of care, of perception of the way of conducting an own life and own existence, to an evidence, a data that can be used for claiming needs at the level of health planning or health delivery center. So we can see that from those data, we can claim to provide and obtain to provide the provision of clinical services as standard of care. So hospital with transfusion center open late in the afternoon, for instance. And on the other side, at the health planning level, a formal recognition for some rare disease of this of disability, impairment, and handicap when it's need to receive the transfusion. So having more rights to more days off from work. Next slide, please. So now we have seen why those are important also for advocacy itself. And now I want to talk to you about some tools that already exist that are within the ERICA project. So as you can see, this is the team, the three of the team are here today. So it's basically coordinated by three organizations: Orphanet, MAPI Research Trust, and the EURORDIS represented by Celine, myself, and David today. So next slide, please. So this is inside of ERICA, so the European Rare Disease Research Coordination and Support Action, that has basically the aim to coordinate the research among the 24 EURAN, said really in a nutshell. So within the working package 3, that is the one dedicated to patient-centric research, we have established this PROMS repository. It is open, accessible online. You have the link. So as you can see, you can search for PROMS. You have there the search engine when you can write your exactly your needs. And then what it appears, I was forgetting to say that we have collected almost 300 PROMs developed in rare disease. Then 150 PROMs that are measuring functional impact. 5 are generic quality of life PROMs. 216 are in the interest of the EURANs, and 161 are for assessing healthcare management. Next slide, please. So once you search for the PROMs, then you can see several content appearing. So you can filter the PROMs and look for your information. So you have author information, the condition of use, the translation, because we know language is one of the huge barrier when it comes to, well, rare disease, but in general. So if translation are providing, the population of development, is it targeting for pediatric, aging patients, adult patient, transition, teenagers, the review copy, and finally the information of the development and validation. Next slide, please. Then just for quickly mention that we are now launching with this project to a pilot on PROMS implementation with the within the EURAN. So we have one example with the EURAN transplant child that is PROMS associated to registry, the PETER registry, that is gathering PROMS questionnaire that are administered via a mobile application. And the scope is monitoring the transplant phases for pediatric population. And then within the EURORDIS, a PROMS that is associated to clinical trial for PKD, that is a rare blood, rare disease. Next slide, please. So now I pass the floor to my colleague Gavin that will explain how patient advocate can further contribute to the ERICA project. Thank you.
Maybe Gavin, we can stay online and I will follow your flow.
Okay, that sounds great. So the real question right now is how patient advocates can contribute. And, everyone here today is a patient advocate in one way or another, and we're thrilled to have you. But basically, one of the best ways that you can contribute to this work package 3 and Erica's work is to submit your prompts of interest to be implemented in the repository. And this is a new feature that's going to be added in June of this year to that repository that we just saw with the link in the discussion. And that's a great way to connect directly with us so that you can, push these prompts up in kind of the visual sense so that we can add it and kind of spread the good word. Another way that you can contribute is by annotating your disease. So this is the Disability Orphanet project, which is the project that I've been managing for a number of years. And the aim of that project is to document the functional consequences of RD, or rare diseases, on daily life. And the way that that's done is by conducting 1-hour semi-structured interviews using the Orphanet Disability Thesaurus, which is adapted from the World Health Organization's International Classification of Disability and Health. And basically, the way that you can get a hold of us to participate in this project is by contacting disability.orphanet@inserm.fr. And what this project is really trying to do is look at rare disease and try to document the impact on daily life by looking at both the severity, the frequency, and the temporality of this impact on several different domains. There's 10 subjects, including motor skills, understanding and learning, ability to participate in social life, and so on. Unfortunately, there's not enough time to talk about this, but we could go on for forever. But the reason why is to build upon the knowledge of clinicians and the patient associations, and to increase the number of rare diseases or subtypes that are indexed online, and to feed into the clustering work, which I'm about to present right now. So basically, this is a project that's been going on for years now, this collaboration between MAPI Research Trust and Orphanet, and now with the help of EURORDIS. But basically what we did was look at the Orphanet classification and the mesh terms and cross those to kind of look at what's going on in terms of RD and instruments available. Then we cross that by looking at which diseases or subtypes have already been assessed according to their functional aspects, looking at these domains. From there, we get a sense of which diseases or subtypes have certain limitations. This could be a permanent limitation affecting your ability to write or receive a message, perhaps your ability to walk outside or short distances, long distances, or within your home. So all these very important factors in daily life. And what you see is, you have this map of what's happening over the course of time. Now we're asking, how are diseases similar or different, regardless of where they are in terms of classification? So we get into these multivariate analysis, so statistical clustering to form groups and look at diseases in a different light, maybe a way that we never would have imagined, diseases that have a different entirely structure to them, and you would never even think about in terms of functioning. But anyways, the idea is to look at these diseases, use these mathematical models to see which diseases have similarities, both in terms of larger impacts and perhaps lesser, and looking at severity, frequency, and the actual impact itself, to see whether or not there are instruments that have been developed, for instance, one's sleep and how that's disturbed. Maybe that's part of a different disease, that is completely unrelated. And so perhaps this is this kind of self-feeding model to look at diseases in a different way, and it can help perhaps you find a problem, that can be of interest to the disease that you're looking at. And so that's about it. Thank you very much.
Perfect. I think we have a couple of questions for you, and then we can open the floor to the participants in case they want to share their experience or have additional questions for the panelists. So at the beginning of your presentation, Charlene asked, you evaluate the impact of treatment, but how can you know if a good or bad impact is due to treatment? Who would like to answer?
I can try to start. I mean,
Okay.
yeah, it's not an easy way to know. I think one way is, as Dagmara was saying, that quality of life is a multi-dimension concept. So if you have a score, if you have a questionnaire measuring different domains, and each domain has a specific score, then you can see maybe where the treatment that you're using is actually impacting the disease. If it's more on, I don't know, the functional impact, if it's more on the sleep quality, or if it's more on the emotional side, I think that could help to have a better understanding. It's not like if it's good or bad, but more which aspect of the quality of life is really impacted. And then you also have like statistical analysis that will help you to see if it's statistically meaningful, and those and therefore if it's has an impact or not. I don't know, Gavin, Marangela, yeah, you want to add something?
Thank you, Celine. Well, indeed, as you said, it's complicated when it comes to quality of life, because it's like a multitude of content and a meaning of one concept. And here, for this complexity, I think also one of the task we would hope in the future that will be increased is the education to public patient involvement in research, because I guess that when the patient is and also the caregiver, if he's the caregiver answering the questionnaire, is training, understanding the objective of the prompts and the objective of evaluating a treatment, could also assess in an initial phase the way of answering, separating what comes from the treatment and what comes from external of the treatment, even if sometimes it's even difficult for the person to understand it. So it's challenging. I'm not saying that education is everything, but it could help.
Yeah, Angelique has raised her hand. I think she would like to add something to this discussion. Angelique?
Yeah, sorry, I don't know if you can hear me.
Yes, we can. Yes.
Hi, Angelique.
Yeah, I was also wondering how complicated it can be to really measure in questionnaires the fact that for an equivalent severity of the disease, sometimes the perception that people themselves have of their disease can differ so much. We sometimes see, or in our organizations, patients with less severe forms that will do less things in life and put themselves more limits than other patients with very severe types of a disease. And how can this truly be evaluated for a questionnaire? That was my question. Thanks.
Yeah, that's a good point. That's really where the complexity lies, and it's also maybe there are also different. The fact that prompts can be used on different aspects could be also to have prompts used for the communication with the healthcare professional, also to get a sense of to better understand how the patient feel, and also how to have a better understanding of the patient itself, and then to add an extra layer on in this patient within the trial. I think there are two aspects that could be targeted, but it's true that it's where statistics also lies, where it could help to even if you have a different response, even if the severity is the same, then statistical analysis with a certain number of patients can help to at least have a trend, and to show that anyway, for example, this impact this functional impact is very important with almost all patients. I don't know if maybe all other my colleagues, maybe Dagmara or Elizabeth, want to add something as well. Please feel free also to complete with your perspective.
Yeah, I would add that it depends what you want to measure, what the outcome is, what the actual PRO is,
Yep.
and if, patients have right to their experience and feeling the way they feel, and then it depends what you do with that information. And like, for example, we do know that there is quite a difference between certain outcomes that are assessed by a doctor and reported by patients, and some are underreported and some are overreported depending on the source. So it really depends what you want to do with the information, what your aim is, and then what you use to measure it. So yeah, it's really a very complex question because it really starts with your aim of using PROs, PROMs, and so on.
Werner has also added, has raised his hand. Werner, can you unmute yourself?
Yeah.
Okay.
Okay. No. Can you hear me now?
Yes.
Yeah.
Yes.
Yeah.
Okay. I have a question to Marie-Angela. Marie-Angela, we were talking about making a survey about the accessibility to a medication, to interferon in Europe for our disease, for our rare disease. But I guess that's a survey, that's not patient-reported outcomes. It's just we want to know who can get this treatment. Could we combine it to patient-reported outcomes questions? Do you have any idea?
Thank you very much for your question. So indeed, so within the EURORDIS, just for explaining also to the audience. Yes. Thank you. So we are launching a survey for mapping the accessibility to interferon, that is a drug used within the scope of myeloproliferative neoplasm. So we are going to assess the accessibility and the reimbursement status, because, well, we know sometimes treatment are validated but not reimbursed. So can we associate then a PROMs to this kind of results? I will say yes, of course. Like we can compare the quality of life of people receiving the proper treatment with the quality of life of people receiving not proper treatment, just for giving a first quick answer. But then, of course, we need to brainstorm about the objective of both surveys and the results we want to achieve. But yes, of course, it's something that could be used, as said, for claiming health planning, standard of care, accessibility to treatment also, indeed.
Great. Vlasta?
Okay, so we have to manage it. We have to find the right questions. Thank you.
Hi, I just want to share my experience with very rare skin disorder, epidermolysis bullosa. For a long time, we patients were included in you know, they were asking them for opinion, you know, what is the most important. And researchers were actually surprised, because they were not just, you know, healing of the skin. The most important for patients were itching. Itching. So, but it's always, and I don't know how we can combine a very difficult this, what the goal for researcher is, with the goal for the patient, because the interest, it's really extremely different, you know. For researchers, they want to know why something appear, and for the patient, they want to know how make them life easier, the better quality, of course. So, but it's difficult also especially in rare diseases, because the symptoms are so individual, so different between patients themselves. So a lot of it needs, I think, a lot conversation and collaboration with patients' organization and with patients. At the end, of course.
Thank you for that, because I think you're highlighting one of the most important things is first to know the disease, the natural history of the disease and how the disease impacts the patient. And it means interviews of patients, interviews of patient advocates with clinicians, just to have a very clear understanding on the disease impact, and then to pick up the right questionnaire that is actually measuring those symptoms, even if not all patients have actually those symptoms, but if you're broad enough to cover all the symptoms that has been mentioned by the patient, then you're pretty sure that at least you will have you will target what is actually impacted by the patient. Yeah, thank you for that.
Add in, considering the Orphan Disability Project, I mean, the real objective of this project is to, you know, interview both clinicians and patient associations. And it's astounding to what point many medical experts who are completely dedicated to their patient population will say, you know, to be honest, I don't know the answer to this question, whether it's regarding temperament, behavior, sleep, whatever. I mean, and they're very quick to say, you know, you should reach out to patient associations because perhaps I haven't asked this question, perhaps I don't have the time, perhaps a patient hasn't spoken about it. But I think that's really interesting is when you have both parties at the same table working together to really, you know, put this knowledge out there. And that's partly why, you know, the Disability Project was created. I mean, obviously, when you're looking at POMs and PCOMs, these are instruments that were specifically tailored with the disease in mind. And what we're doing is just using the same questionnaire, kind of taking a little cross-section of the ICF and asking, you know, specific, but also very general questions. And it's just amazing. I mean, all the work that everyone's doing with PCOMs and PROMs and really getting into the kind of nuts and bolts of what's actually going on, you know, over the course of time. But yeah, I agree. I think it's important to have each voice, but also the voices together as well, because they complement each other so well.
Perfect. Christine, you also have a question?
Yeah, it's not a question, it's just an answer to what was asked before and what Gavin just said. I think important is to keep in mind, if we as patients ask questions how to solve our symptoms, our struggle with the symptoms, this could always lead to another idea of structured work on the problems we have with our illness and with our disease. So as Gavin just said, it's very important to put those things together, because it doesn't help us if someone is thinking about some treatment we even don't think about as patients, because we don't need it. Our symptoms and our daily life with the illness will show what should be the way to solve the problems with this disease. And for sure, it's sometimes you only have one symptom which bothers you very, very much, and the rest of the disease is also systematically. So we need to have systematic cure of the disease. But in the first moment, if you ask patients, it's always the daily life what leads to the next step to do. It's my impression. So this is, what I think, if you ask patients, you will always get the point which is hurting very much in the moment. And if you ask the question a bit more like, keep your eyes in the future, think about what is important for your children or for the next generation with this question, then you will find out what could be the different point of view from the clinicians to solve those problems. better. Thanks.
Thank you. Would you like to add something, Celine or Mariangela? Okay, we have a few more questions that were asked during the presentation. I'll just read them out loud and you can jump in. Nud asked, how easy to get hospitals to use prompts or the results from them?
Do you know, maybe Mariangela, do you have, since you're more in contact with
The hospital. No, I don't have this data. I cannot say how often hospital associate them. No, I'm sorry, I don't have it here. I'm trying to recall in my memory if any kind of analysis dropped in my pathway. No, I'm sorry.
Yeah, Dagmara, also feel free to jump in if you would like to share your experience as well.
Yeah, in our experience, there are some hospitals that use PROs. Well, for us, it's in cancer in clinical practice, and they use it for everybody. But that's still really depends on the hospital and their management and what they want to do. So yeah, it's not yet done on a big scale.
Yeah, I think we can also send this question to Elizabeth and she could share the patient group perspective. Unfortunately, she hasn't been able to join us again, and we've prepared a list of questions that were asked during her presentation, and she'll provide the answers via email, and we'll put them in the alumni page along with the rest of the information. Eva also asked a very interesting question about getting enough respondents to a prompt for it to be meaningful. And I think Elizabeth would be great if she could answer that question too, but wonder if the panelists here could also give us their thoughts. The question reads as, I'm wondering on how to achieve, as a patient association, getting enough respondents to a prompt for it to be meaningful. How do you influence the uptake in order to achieve statistically meaningful results?
Here, maybe I can share my experience with Patients Association. So what I've seen is that Patients Association and patient community also feel like the responsibility of being more involved in this kind of research when they, of course, understand the objective, how the result will be used, and directly how their contribution will impact research. So I think we should see also on the other way around. So in order to have more and more patient-centric research, we maybe should start systematically to share the results with the patient community in order also to increase the participation to prompts. So like I see the result, I see how important is my contribution, so I get more and more involved.
Perfect. Adrian also asked, in what ways can prompt data influence healthcare policies and resource allocation, ultimately leading to improved patient experiences and outcomes? Who would like to take this one?
That's basically what the point of health technology assessment is, and allocating resources based, the PROs are used for that, and there is a whole field that does lots of calculations that are definitely above my level of understanding on how to get the data from quality of life questionnaires, for example, to calculate QALYs and that sort of things. But that's a whole different topic, I would say.
Yes, agreed. Shayla was making also a reflection on how difficult it is to get healthcare professionals to take part in such questionnaires due to time limitations. and she would recommend highly focused questions and limited in number. I was wondering if you agree, would like to add something.
Yes, maybe here it's yes, it's one of the criteria that we will allow, because we know that for to have, it's very important that clinicians are also convinced about using prompts to also get patient with them. So we know that clinician, to convince the importance of prompts to clinicians, we know that it's very important. And one of the criteria is that the prompts should not break the clinical flow. And one of this is, you're right, to make sure that the number of item is as short as possible, I mean, as small as possible, and very focusing on what the clinician wants to measure. And we go back to the very initial question, which is to be sure that what you want to measure, and then to dive into the resources that you have to see what kind of questionnaire has been developed by other and that you can use. So yes, it should be short, it should be actionable, meaning that you need to have a score quite quickly, easy to understand, and easy to interpret. And that's a good, I think that's also a good start. And to see also how powerful those data could be to really influence patient experience. Exactly the example that Marie-Angela shared, that as soon as you have data, not from one patient, but from 10, from 20, the more you can bring data on the table to change things within the hospital first, and then maybe could be maybe a broader influence. But it's true that short number of questions, short number of item, easy calculation. And also, we didn't talk about this, but the electronic aspect of questionnaire as well should be mentioned. We know that e-version could be helpful to gather the data, to smooth the process of assessing the questionnaires, and also for patient to answer the question remotely. Have many pros and cons, but among the pros is really to get their feedback easily. They don't need to travel. Maybe you can also assess more stigmatized symptoms when they are at home. But we know also the cons that are on technology literacy, the accessibility of technology, all this aspect, but maybe also technology could help as well to get everyone in the boat, both patient and clinicians, and a hospital by extension.
I see in the chat that Susie Ann is making very interesting comments on how to approach hospitals to get to use the PROM outcomes. I was wondering, Susie, if you would like to unmute yourself and share your experience. Feel free to do so. There are two final questions that were kind of answered in the chat, but I thought it would be nice to also ask them here. Gina was asking, we are developing a survey on adherence to treatment for patients with IPF. Would it be possible to publish it later on OrphanEd?
Yeah, I think, all of these requests, I think they take time to consider, but I think, are you speaking specifically about the repository or in which sense? Sorry.
I don't have more information, so Gina, if you would like to unmute and tell us a little bit more about it. If not, I have one final question for Gavin. Eva was asking, could we get some concrete examples of the reclustering of disease groups?
Yeah, so we're still kind of analyzing this data. And so roughly we have about 44 clusters, and we're looking at, the statistical importance of each of these clusters and looking at whether or not there are instruments developed, and still in this kind of triage phase of kind of, really looking at what is important in this tremendous amount of data that we have. But what we've initially seen is quite fascinating in terms of, different diseases that have nothing to do in terms of what you would normally think of, at least from my perspective, looking at the orphanet classification. And this could be something that's, strictly visual, but this could be something that's also has an impact on motor skills or social life, and really kind of looking at rare diseases in a very different light. And unfortunately, we're not able to present this data at this point just because we're still waiting for ERN coordinators to kind of validate it and looking for some external kind of, verification and so forth. But I mean, we're really kind of digging deep, and we're going to do a kind of initial presentation nearly next week. And I think it would be just too early at this point in time. But I think it is promising, and I think it's a great way of looking at POMs in this way, and really trying to see, like we saw in like Mara's first presentation is, what is out there. The idea is not to recreate the wheel, and to be inspired from existing instruments and see things like that. But yeah, and I apologize. I mean, we could take 45 minutes to really go into that work. I felt like my brain was going to explode, but it's really interesting work, and I'm happy to be part of the team. So
yeah, thank you for sharing a little bit more about your work and what you're doing. I don't see any more questions in the chat. I think that we can wrap up here. I've saved the chat messages because